today. I'd like to welcome you to our Implementation Research Group Cyber Seminar. My name is Christine Kowalski, and I am an implementation scientist, and I lead the Implementation Research Group. This session today is part of our catalog of monthly events for this learning collaborative, where we focus on sharing best practices and lessons learned in implementation science. And as a group, we're always working together to advance the field of implementation science. We have over 500 members in the group now, and if you're interested in joining the IRG, you can reach us at the email address irg@va.gov. And now I'd like to thank our presenter for her work in preparing for this session today. Dr. Christine Hartmann will be speaking. We're thrilled to have her. She's a supervisory research health scientist for the VA Center for Healthcare Organization and Implementation Research, known as QUERI. She's a co-director for the VA CLC's ongoing National Center for Enhancing Resources and Training. She's the director of the QUERI Teamwork Training Hub that she'll be speaking with us about today. And she is also a research professor at the University of Massachusetts Lowell. So we hope that you all enjoy the session today. And now I will turn things over to Dr. Hartmann.
Christine, thanks so much. I'm really thrilled to be here today, and thanks everybody for joining. As Heidi said, we're going to make this as interactive as possible, and so you've been looking at this first question here on the screen, which is all about your team's culture. And really that's what we're talking about when we're talking about teamwork. We're talking about things that happen within the culture of your, whatever it is that you're thinking about when you think about this slide. So I didn't say within your research group, but think of one group in which you are a member and think about the culture in that group. It could be a research project that you're doing or a workplace organization. It could be your home. What aspects of the things here on this screen do you do well on, do you do not so well on in terms of communication? How frequent, timely, accurate problem solving is the communication that you have within that group, within that culture in which you're operating? And then do you share knowledge, do you share goals, and is there mutual respect? These are the kinds of things that I'm going to be talking about today because they are central to teamwork, and that's central to the Teamwork Training Hub that we have through the generosity and support of QUERI. And I am speaking today on behalf of other people. Lynn Snow as my research partner. She's at the Tuscaloosa VA, and Cami Pimentel is at the Bedford VA with me. And together we help run this Teamwork Training Hub, which is really all about the various aspects of teamwork and how you can change the culture of the teams in which you operate to operate more efficiently. So as Heidi said, we're going to be doing this interactively, and I'm going to be relying on all of you. We have almost 100 participants. That means we have almost 100 great brains in this room. So your participation in the Q&A piece, where I'm going to ask some questions on the screen and you're going to type your answers in, is part of your own learning experience as we go through this, but it also has an altruistic component, because the more you participate, the more other people will be able to learn from you. And as I said, with 100 great brains in this room, we all have the opportunity to learn from each other. So I really hope that all of you participate, and actually the next slide will give you the opportunity to do that, because I'd like you to start off by typing into the Q&A that team that you were thinking about with slide 1. What are some things that you would like to change about your team's culture? Just think for a second about that team, whether it's a workplace team, a home team, whatever team it is that you are thinking about. Just pick one that you're working on. I see things coming through like communication, that you would like to have more effective communication. Accountability, I see. Trust and shared knowledge, a shared belief, and that you are feeling maybe that you're asked to do too many things. Frequency of communication. I see communication coming up a whole bunch. That communication can be complicated, and that every person in the team should feel like an important team member and take responsibility for their piece. There are a lot of things that you can think about as you are thinking about that, valuing team members. These are all ideas that we're going to think a little bit more in depth about today. So thank you so much for putting these things in. I can see that there are even more coming in, willingness to explore new ideas. These are all great, and I'm sure that as you see other people's answers, you're also thinking about your own teams and maybe nodding your head thinking, yeah, those are some of the kinds of things that we could also perhaps work on. And maybe you're even thinking of new things that you didn't realize that you wanted to be working on. So when we think about working on things, we're actually creating a learning system. We're doing continuous quality improvement. And when you think about creating, for example, a learning healthcare system, one of the things that you need to do is to think about, so I can see that I apologize for my flipping ahead to the next slide, but I can see that the animation in my slide isn't working. So for some reason, I can't get the next things to click up here. But what should have happened was that on my next click, creating a learning health system should have then shown you culture change is required to create a learning health system. So that arrow should be pointing to culture change is necessary for creating a learning health system. And when you think of what's necessary for culture change, what's necessary for culture change is behavior change, and that would have been the third box here on the right-hand side. So when you think about creating a learning health system, you can break it down to, well, to create a learning health system that embraces continuous quality improvement, we need to change the culture so that the culture embraces continuous quality improvement. And when you think about continuous quality improvement, what is necessary, when you think about culture change, what is necessary for that is behavior change. We need to have people change their attitudes and behaviors, because what is culture except for the communal sense of the way we do things around here? And so what we're really going to be talking about is the way you can change people's behavior and improve their teamwork so that you can create a culture that embraces effective and high-functioning teamwork that will then help create your learning system. So, again, this should have been animated, but let's start with the right-hand side. One of the ways to change behavior is a stick approach. The stick approach is perhaps maybe what you grew up with to a certain extent. Maybe your parents were parents that took a disincentivizing approach. Maybe you feel, and you can easily identify things that happen in your workplace that concentrate on disincentives for doing certain things. So that's one way to change behavior. If we go to the far left-hand side, we also see a trash can. So a trash can, in this case, represents another way to change a culture, which is sometimes there are toxic individuals in the culture, and they are driving the culture that is part of your organization. And in a corporate world, it is sometimes easier than other places to nudge those toxic individuals out and hire based on certain criteria for the culture that you want to create. But in VA, which is where I operate, it is difficult to remove individuals from their job positions. And if you're thinking about your home when you're thinking about your team, you know that it's impossible to remove people from your home. So we're really left with the alternative here of the carrot. And I'm going to concentrate on the carrot aspect, because that is really what our Teamwork Training Hub focuses on, and all our work in the VA, in the 134 nursing homes in the VA, they're called Community Living Centers or CLCs, really focuses on this carrot approach, because we find that this positive reinforcement is a very powerful tool for changing behavior, changing the culture, and therefore developing a continuous quality improvement system. So we have done all our work in those CLCs in collaboration with the people who work and live in the CLCs. So from the get-go, we have operated on a teamwork approach, because all our studies and the now national quality improvement work that we've been doing for close to 5 years with all the nursing homes in the VA really is done hand in hand, coordinated with the staff at the VA CLCs and the leadership of the CLCs. We also operate at the VISN level, which VISN is the VA's larger regional level of operation, and at the national level. So we have done all our work already hand in hand with all these different teams. And we've done it with this model for behavior change in mind. This is called the COM-B model. That's all those first letters of all those words that you see on the screen. And the COM-B model posits that behavior is influenced by what you see here on the left, the capability, motivation, and opportunity that individuals have. And capability and motivation are internal to the individual, where opportunity functions outside the individual. And capability is someone's ability, their knowledge about something that influences their behavior. Motivation is this emotional component for the behavior, and then opportunity is the pieces in the environment that are helpful for driving the behavior. Now, if you are familiar with me, you will know that I love Chip and Dan Heath. And Chip and Dan Heath happened to write a book that is really important in thinking about the COM-B model. Chip and Dan Heath have written a number of books, all of which you see on this slide. The first one on the far right is Made to Stick. That was the first book they came out with. It's a fantastic book. Their second book was Switch. And Switch is the one that I am going to concentrate on today. They also wrote Decisive and the Power of Moments. But I don't know if you can really see it in this slide, but the reason that arrow is there at the top of the Switch copy, that's my Switch copy. And there are lots of dog ears in that book because I love, it's like practically every other page it looks like. I just love so much of what they have to say. So if you haven't had a chance to look at any of the Chip and Dan Heath books, I recommend them all. But Switch, if you're thinking about behavior change, Switch is a really powerful book that is very easy read and yet has incredibly applicable stories and techniques for helping facilitate behavior change. So I'm going to tell a story that is in the Switch book. And again, this was supposed to be animated, so you weren't supposed to know all this information right from the get-go. But let's work with this right now the way it is on the screen. The story is about an elephant and a rider. So that's that person at the top and the yellow box elephant. So here we have a person who is sitting on top of an elephant. Let's say that's the story that we're thinking about. And this person is sitting on top of the elephant, and they're wandering through a jungle. Now, in terms of getting that elephant to do the behavior, the person has ideas of where they want to go. They have a destination in mind, and the elephant doesn't know that. The elephant is the elephant, but the person, if you think about it, could probably, if that elephant is calm and perhaps trained, that person can perhaps direct that elephant in the direction that that person wants the elephant to go. But if you think about the weight difference between a person and an elephant, I was going to actually have you guess in the chat box, in the Q&A about how much an elephant weighs, but here we go. And I did the person weighing 200 pounds for ease of math because I'm not very good at math on the fly. So I can look at these numbers and remember that there's about a 60-fold difference in the weight of a person as compared to the weight of an elephant. So if you think of yourself and you're sitting on top of something that weighs 60 times more than you, then you will realize that you don't actually have a lot of control of that elephant if that elephant gets really motivated to do something different. So this is an exemplification of the power of the different pieces to motivate behavior. Because there may be a path through the jungle, and you can think of that as the opportunities in the environment. And so the elephant, when calm, and you as the rider directing the elephant may be very capable of keeping that elephant on that path. But if that elephant gets spooked and that elephant has a big emotional reaction, what's going to happen? You have no control anymore. The path won't matter. The elephant is going to take off through the jungle the way the elephant wants to go. And I think this is important to remember because it is actually mapping onto COM-B. And when we do our work with teams in the CLCs, one of the things that we find really helpful to remember is directing the rider through for example, presentations like today where you have PowerPoint slides and facts, that can be an important piece of motivating behavior. Shaping the path, making certain things easier, perhaps making the things that you don't want people to do a little bit more difficult. That is also important for motivating behavior. But sometimes, really, for getting behavior to get going and to jumpstart some sort of behavior, it is important to remember that the emotional component of behavior change is a really powerful tool. And you can access that through stories, through videos, and we have tried as much as possible in our work with CLCs to have people either experience in real time an emotional response to something, and then we support that emotional response in getting them motivated to do a behavior that will help them create a better team, or we create motivational videos, for example. So I encourage you to think about this in terms of COM-B, but if that's a little bit hard to access, remember, direct the rider, motivate the elephant, and shape the path. That's how you can help change behaviors. So I'm going to ask you again in the Q&A, would you please indicate in the Q&A box, in thinking about that culture that you were thinking about when you responded the first time, which technique comes first to mind for you if you were trying to change that culture? Remember, you talked about the things that you would like to change. What would you use to change the culture? Would you use and there's no right answer here. You have to think about your own culture. Would you direct the rider? Would you motivate the elephant? Would you shape the path? Do you have some ideas about which one of those things might be useful and how you would operationalize them? So I'm looking for the people to respond in the Q&A box. I don't see anything coming through yet. I can tell you that there are some times when I really feel as though there is a time for directing the rider. It is an important time for people to get information that is very fact-based, for example, around COVID. It is very important sometimes for people in the CLCs. We knew at the beginning they wanted facts, they wanted them often, they wanted them to be accurate as possible because we were all lacking so many facts. So there is definitely a time for motivating the rider. And I can see that some people are using a combination of directing the rider and motivating the elephant by using data plus a story. And then some are incorporating all three things together. And then the environmental change is also extremely helpful. And then some people are saying here, motivating the elephant, but doing it in a step-by-step approach. So it's also very clear what the path is. Shaping the path, some people say that they found it easy. If it's easy, then people will take it as an opportunity. If it's more difficult, then people will not recognize that as an opportunity. So I think you all are really understanding these three important components of behavior change. And so now we're going to operationalize those a little bit more in terms of teamwork. And you may all be familiar with this framework, but this is really what our work is based in. It's the framework of relational coordination. And that frequent, timely, accurate problem solving with shared goals, shared knowledge, and mutual respect. Again, this was supposed to be animated, so that is actually covering over all the positive outcomes that have been found in the literature where teams that are relationally coordinated have better outcomes in all kinds of venues, including, in our case, including in nursing homes, but in all kinds of venues, both inside healthcare and outside healthcare, because this is a framework that was actually developed outside of healthcare and has now more recently been incorporated in healthcare. So again, I'm sorry that the animation didn't work and you can't see what is underneath this frequent, timely, accurate problem-solving box there, but it does show all the positive outcomes, and you can easily look in PubMed or Google relational coordination, and you yourself can find out all you want to know about this wonderful framework, but it is one that we rely on heavily in our work. So in your culture that you were thinking about before, or in this case, you might want to now narrow in, if you're doing research, what kind of, and I assume it is a healthcare-based research, or at least a human subjects-based research that you're doing, and you might want to think about that culture. Where are the places that culture is really stellar? What is it doing that is excellent in terms of these aspects of relational coordination here on the screen? So think, pick one thing to concentrate on. And I see that mutual respect is something that is coming through that Louise said, and mutual respect is a really key piece to understanding how to form a good team, because if you don't have this mutual respect, you are not going to listen to each other. And I see that has been indicated by other people as well, that mutual respect is something that they are doing really well on. That is a super firm foundation on which to base teamwork. So when you think about the teams in which you operate, this is one of the things that you are going to want to understand, where you are performing really well, because those are the places that you can lean on when you are pushing for some sort of behavior change. Now I've changed the question to being where that culture that you're thinking of does the least well. So it's also important to identify where the culture needs some work and where you're going to want to focus your efforts the most. So when you think about that culture that you have in mind, where is it performing less well? Where among all these things does it not work well? And I can tell you that, so for certain cultures that I'm thinking about, the timeliness of communication is definitely lacking. And so when you think about, and I see that is echoed by someone else, the timeliness of communication is actually something that can be difficult because the people who have the information feel like they know it. And so timeliness, if you're in a leadership position, you know all the information. It may not be something that you're aware of, that other people are feeling as though timeliness is an issue, because you know all the information, and the fact that it's trickling out of you slowly doesn't bother you as much because you have everything it is that you need to know. So I also see that shared goals and then people not dependably showing up, which I think would point to a mutual respect issue. So in terms of thinking about changing that system and making your teamwork better, it's really important to think about the continuous quality improvement idea that your systems create your outcomes. So when you have a system and you are doing the same thing and you are getting the same outcome every time, in other words, if you have lower performance on something and you are operating within the same system and you're not changing that system, but you're thinking maybe my performance will change anyway, that is like this cat in glass in this picture. If you're doing the same thing over and over again and you're getting the same result, it's because your system is designed to create that result, and you must actually change that system. And that is what our foundational principle for this Teamwork Training Hub is really all about, which is this collaboration in the LOCK framework. So let me just take a moment to describe LOCK. LOCK is something that we developed in our research program. It was something that was developed, as I said in that slide earlier, where you saw all those figures pushing up the word teamwork. This was based in work that we did in the CLC, starting with CLC staff. And what we did was we had an intervention that we wanted to implement about improving interactions between residents and staff and resident-to-resident interactions. And this framework was built off of that. What we realized over time was that for implementation of what we wanted staff to do, we needed to have staff do 4 things. That we needed them to look for the bright spots, to conduct observations, to collaborate in huddles, and to keep everything that they did in a bite-sized way. And so I'm going to go into all 4 of those just really briefly on this slide. There's a lot more information out there in the literature about this, but looking for the bright spots means for having a positive deviance approach. So when we think about teams in healthcare and how they are evaluated and healthcare outcomes, we are often looking at negative things, especially in nursing homes. We're thinking about pressure injuries. We're thinking about falls. We're thinking about, people who aren't washing their hands, infection control issues. We're thinking about all these places where things are going wrong. But the literature shows, the positive deviance literature shows, that looking for places where things are going right is actually a key to understanding how to do things better. So if we think about, let's think about pressure injuries, for example, right? What you might know as a pressure ulcer or a pressure sore, a bed sore. Those are, unfortunately, can be very common in nursing homes for multiple reasons. And so what the quality measures tend to do is focus on, okay, so how many residents in your nursing home had pressure injuries? Well, it's important to look at that information, but it's also important to look at who was at risk for developing a pressure injury but did not develop it. That person is your bright spot. That person is a place where things are going well. If you're looking at infection control or hand hygiene, for example, the times where staff are washing their hands or are using the hand sanitizer, whether that be a certain person who's doing it all the time or a time of day when it's done or a place within the nursing home or hospital where people tend to do it as opposed to all the other places where they're not doing it as much, the places where things are happening give you the information that you can use to spread the bright spots. So our program in CLCs was initially called the Bright Spots Program for this very reason, because we had staff concentrate on areas where things were going well. We had them conduct observations, that's the O of LOCK, and we talk about big data and small data when we are talking about what we're doing here. In the Teamwork Training Hub and our work with CLCs, we talk about big data, meaning these administrative data. We don't mean big data in the sort of Facebook, Google kind of sense of big data, but rather big data meaning the administratively collected VA data that gives you a sense of who has the pressure injury, who is falling, et cetera. But we also talk about small data, those data that staff can collect quickly, just from today to tomorrow, using a structured instrument or not, using just their observation, and then asking people what their observations were. So that's the C of LOCK, collaborating in these frontline staff huddles. Having that opportunity to develop that teamwork and building that structure. So we just said that you can't change your culture and expect things different if you have the same culture and the same structures and processes operating. You need to change your structures and processes. And for us, a huddle is the foundational change that we help the CLCs make in their structures and processes. And then the K is keeping everything bite-sized, because we know from the literature that if you keep things short and sweet, it's actually easier to change your habits than if you have bigger pieces. Breaking things up, somebody said that earlier in the Q&A box, breaking things up into small pieces is a key to keeping things going. So everything that we do in the CLCs, what we have them do is done in increments of 5 to 15 minutes at most, because they are busy clinical staff. So now that you understand a little bit more about the LOCK principle, this is a demonstration of how LOCK works in practice, right? So this is a huddle, for example. They're thinking about directing the riders, motivating the elephant, shaping the path, but what they're really doing is a rapid cycle, continuous quality improvement, PDSA. They think about what they'd like to change. They do some sorts of observations and measurement. Then they analyze that. They discuss and implement then an action plan, and then they go through that cycle again. As I said, there's a lot more about LOCK in the literature. We've published on these, and I'm not going to go into any of this because you can look that up yourself if you're interested. But I will tell you what we've done. We have worked with CLCs across the nation, and again, this was supposed to be animated. The red was supposed to come up first, because what happens with our program in the CLCs, and this is a program funded by the Office of Geriatrics and Extended Care. They have thought our program working with CLCs and helping them improve their teamwork to get high engagement and high performance in the teams in the CLCs. They funded us, as I said, for almost 5 years, and with $1 to $2 million every year for a large team of people. And we were tasked in 2018 with working with 8 of the lowest performing CLCs in the nation. And why that happened was because in 2018, you may not remember, but it's burned into my memory as well as the people on our team in central office. There was a series of newspaper articles that came out in USA Today and the Boston Globe about a quality crisis in CLCs. And don't get me started on whether or not there really was a quality crisis, but regardless, Congress then thought that there was a quality crisis in CLCs, and there was a lot of pressure. And our group, our concert group, was tasked with doing some interventions in the lowest performing, those 8 dots there in red, the lowest performing CLCs in the nation, and doing a learning intensive with them around these LOCK principles, around continuous quality improvement, to now change their clinical outcomes for the better. And after that, we worked with 31 CLCs in the nation who were the remaining 1-star CLCs in the nation. And so we've had a lot of experience, especially working or even working with low performers using these LOCK principles. And again, it's supposed to have animation here. I'm really suffering from this. Next time I will not put animation in my slides for a Cyber seminar. But what you can kind of see here still is that this is the data for the 8 nursing homes that participated, the 8 CLCs that participated in that first round, and you just have to take my word from it that all of them except for H, which had some internal issues that we knew about, did improve a lot because of this training that we did. It was a 9-month training on teamwork, and then the 31 CLCs also improved in their scores. We have data on the effectiveness of intensive facilitated training for teamwork, but this quote is up here because these huddles, these frontline staff huddles, which are called watch list huddles, which I will get to in a second, this is a quote from a medical director at one of the CLCs, and I like this quote because this quote to me operates on 2 levels. So there's the idea that implementing this teamwork training, this watch list huddles, creating this structure and process for creating a high functioning and high interactive team saved their CLC's team, right? That's the surface meaning of this. You can all read that. But to me, this quote also means that CLC didn't really have a team to begin with, right? You don't talk about saving a team when you have a high-functioning, relationally coordinated team to start with. That's the kind of team that doesn't need saving, because that's the kind of team that is cohesive and strong. What really happened was that they created a team, and that is because we helped them put the structures and processes in place. And so for doing that, we used this, what we called a watch list huddle. So this is a frontline staff huddle, and we just recently presented at the IHI forum, and our audience there wasn't nursing home clinicians, rather, but clinicians from all over, and we were talking about how this type of huddling can, with some tweaks, what we did in the nursing homes can be applied across healthcare settings for getting information quickly across the important interdisciplinary people who need to know the information from each other. And so in our nursing home settings, we kickstart these watch list huddles by actually tapping into that elephant, asking staff which resident, so which patient, but in a nursing home, they're residents, which resident did you go home worried about? Who keeps you up at night? Who is so at risk or declining so quickly that you go home worried about that person? And who are your staff worried about? So we start where they are, which is in the emotional component of their job, the people that they are worried about. And those are the people who populate this list that they then talk about during their huddles. And I'd like to tell you a story about how those types of huddles are operationalized. So this is a true story in a nursing home. And when we talk about these watch list huddles, we have them gather staff in a room, and that is a 15-minute meeting. It is a short meeting. So they're really only talking about 5 residents, for example, 3 to 5 residents, at the most 7, because you really can't get through a lot of people in 15 minutes if you stick to the principle of wanting to hear from everybody so that you develop this team approach to care. So in this example, so imagine you have a room, you have the physician in there, you have some nurses in there, you have the nursing assistants who are providing the front line, really hands-on care to the residents. You have dietary, you have housekeeping, you have psychology, social work. So you have maybe 7, 8 people in this room. And we're talking about Mr. Jones. So, for example, the facilitator talks about Mr. Jones. We're all worried about Mr. Jones. Mr. Jones is really at risk, and he seems to be declining, and we need to keep an eye out for certain things for Mr. Jones based on his clinical condition. And then the key to these watch list huddles is you go around the room. Have every person speak. This is the observation piece of Locke. Collaboration only happens if you actually ask all the people to collaborate. So go around the room and ask the physician, the nurse, the social worker, the psychologist, the dietitian, what do you know about Mr. Jones? Anything you have to share about Mr. Jones? What have you observed? The nursing assistant, what did you see? And so in this true story, that took place, and they got to the housekeeper. And the housekeeper said, well, this is my first time here in this huddle. I don't normally talk to you clinicians. I'm just in there cleaning up. But I'll tell you what I encounter in my job is that Mr. Jones, every morning I'm cleaning up some sort of spit that he spit out on the side of the bed. And every morning on the far side of his bed, there's that spit, and I clean it up. I never tell anybody about it, but that's my job. But I'll tell you that every morning I clean it up, it's clear. And this morning I cleaned it up, and it was green. So I don't know if that means anything, but you're asking me, so here I'm telling you. And then, of course, for the clinicians in the audience, you have antennae going up, and that's what happened. So immediately the action plan was that they do an assessment for Mr. Jones. And so the nurse and the physician went and did an assessment. And yes, Mr. Jones had pneumonia, and they were able to intervene really early because of this information. And they were able to stop the decline. And in the next day's huddle, the first thing they did was, thank goodness, housekeeper, thank you so much for sharing that information. This is what happened as a result of that. And we were able to prevent not only his decline, but probably his hospitalization. And goodness knows what might have happened with him if you hadn't shared that information with us. And that is the power of a story and motivating the elephant, because you can imagine that it doesn't take but a few of those types of interactions for that team to understand that they each possess key pieces of information that they didn't have the structure or process to share with each other before. And this is the watch list huddle saved our team. Because when they understand that they can have a new structure and process that doesn't take long, but that gives them critical pieces of information, and they get to know each other through that sharing of the information, they are then building these high-functioning, relationally coordinated teams. And what else they are doing is cycle time. I don't know if you're familiar with the term cycle time, but what it does is reduce the cycle time. So an ordinary cycle time in the situation that I just told you about would be the housekeeper notices that the sputum is green, but really has nobody to tell about it and wouldn't even consider saying anything to anybody because nobody's ever talked to the housekeeper about anything related to, resident clinical care before. So the housekeeper just notes it and then forgets it, and maybe doesn't forget it, but just doesn't say anything because there's no mechanism. Then the nursing assistants throughout the day shift notice things and maybe even tug on the sleeve of the nurse, but the nurse is too busy to listen to a nursing assistant. So then it goes on to evening shift. the information hasn't been passed on because the only people who noticed it were the nursing assistants. So evening shift, night shift, they all notice things, but it's the nursing assistants noticing. Nobody really has a venue to say anything. And it's not until the next day where the nurses come on and they happen to pass by the room and they notice Mr. Jones has declined a lot since they last saw him. And that is slow cycle time. As in the story that I just told you, the cycle time was really fast, right? As soon as the housekeeper saw it, it was a morning huddle. The housekeeper shared that information. Boom, intervention happened right after that. That is quick cycle time. And when you want to prevent things from happening, you need to reduce your cycle time. So one of the benefits of creating these structures and processes where people are communicating more frequently is to reduce the cycle time. And what you're also doing is preventing things getting triggered in your quality measures. So if you're thinking purely from those administrative data perspectives, someone like Mr. Jones, who didn't get hospitalized, didn't end up with pneumonia, goodness sakes, didn't decline so much that he died. People who are at risk today are the ones who are going to end up, if you don't intervene, being those things that trigger those quality measures tomorrow. So what you want to do is reduce the cycle time so that you're not in the tomorrow stance, but that you catch things today. So now thinking back to those teams, I'm going to ask you again to participate in the Q&A box. Are you comfortable with your current cycle time within your teams? Think about whatever team it was, whether it's the clinical team that you were thinking about in terms of your own research, or if it's your work environment team, or if it's the team that you have at home. Are you comfortable with the current cycle time? How long does it take from the person who has the information that is really critical to get to the person who can make some changes and then cycle back through to close that continuous quality improvement loop? How comfortable are you now that you know a lot about your cycle time issue? So I see that some people are comfortable with their current cycle time, and that implies that you have some really great systems in place that are feeding that information as quickly as it needs to be fed. And then I also see some people saying, no, cycle time is actually something that, now that you've pointed out to me, is an issue, or it could be improved. And that is something that you can think about in terms of what you want to improve in terms of the cycle time for your own system in which you're operating, because cycle time can be improved, and huddling is one way to improve it. So again, I'm sharing this slide with lack of animation, but what you can see here, yellow highlighted in the left-hand side, is the shared meetings and huddles is one way to improve the cycle time and the structure and process for creating this team. So this is the system by which teams share information. So we are talking here about watch list huddles. You may have a different type of huddle that you decide to implement in your team, but I'm going to tell you about the success of watch list huddles in the nursing homes. So a watch list huddle is what I just described with the story about Mr. Jones, but it has a specific agenda. So when you are talking about a specific resident, you explain the concerns about, for example, Mr. Jones, and you use that opportunity for a 1 or 2 minute quick clinical relevance, just in time teaching about what are the things that might come up and why those things are important. And then you go around the room and you ask everybody in the room for what their updates are to that current information that you have just shared. And then you do that brainstorming. What are possible solutions that, now that we know all this information, we've just reduced our cycle time because now we have all the information possible. What are the action plans that is the action plan that we want to take, and who is going to run with that? And maybe that action plan is that that resident is doing so well that they can be removed from the watch list, because the watch list in the nursing homes is a completely living list. It changes on a daily basis. You're trying to get people off the watch list, but as you're getting people off the watch list, there are new people that you're worried about. So this watch list is a continuous living it's often a document in that we have often CLCs do a whiteboard or one of those large Post-it notes where they have that information, but it's continually changing. It's not a permanent, if Mr. Jones is on the watch list today, you are hoping that a week from now, Mr. Jones is no longer on the watch list because you've addressed Mr. Jones's issues. We know that this all sounds great and that there are a lot of barriers to implementing a huddle like this. And so I have some of these up here on the screen. There are, if you think about it, in terms of, again, you can think about it in terms of your team experience, in terms of your home experience, in terms of your research experience. There are many ways this type of system creation, this process and structure creation can go wrong. I say the huddles are supposed to be short. It could be that the huddles are running long, and that often happens in the beginning. When you are trying to get huddles up and running, they tend to go over, and so it's difficult to, but not impossible, to and there are ways that they tend to go over, so there are known ways to address the things that make them go over, and to get them to be on time so that people feel respected for the time that they have and they feel heard during that time. That's also in terms of starting on time. Leadership buy-in is really key, and if you have staff who are used to operating in silos, then it can be a barrier to getting people to communicate. But that's where that motivating the elephant having, and let me tell you, I could spend an hour just telling you story after story after story after story that each one would move you about the information that nursing assistants, that dietary staff, that housekeeping staff shared that were key to changing things that had been intractable before those people were pulled into the huddle. But they were so used to operating just within their own silo that information never got shared. If you don't have leadership involvement and mentorship for the facilitator for your huddle, that can also be difficult. And then, of course, there's not hearing from frontline staff. So in terms of teamwork training, we have actually created a series of videos on good huddle facilitation. And these, if you get the handouts, these are actually hyperlinks within the handout. These are Googleable. They're on YouTube. So if you search YouTube, if you actually search YouTube for concert watch lists, huddle facilitation tips, they should actually come up. But these are actually hyperlinks. So we've created a series of videos for the 4 things that we find often derail huddles. So, this time management issues and the issue of participants who are either completely not interested and therefore not participating in the huddle, or raising really difficult questions, being very negative, and then off-topic interruptions and how to handle those. So we have those up if people are interested. So now I'm nearing the end of the presentation here, and I'm just going to ask you again to think about where you work and what conditions or treatments or whatever it is that applies in your case. What are those things that require watching, teamwork, and escalation? And is there a place for something like a watch list huddle in your team? So again, if you want to type something into the Q&A box, and I will just, as you're typing that in, I see a question in the Q&A about how COVID is impacting huddles at CLCs. That's a really great question. We have addressed that in concert because, of course, initially CLCs were completely shut down, and so we came up with a tip sheet, and we have coached the CLCs because we do individual and business level coaching for the CLCs on how to conduct huddles where some or all of the team members are remote. And we've actually had CLCs that have had, come back to us and had tremendous success in doing it remotely, and actually found that doing the huddles remotely had some benefits. For example, someone was in front of the computer while they were huddling as opposed to standing up in a room, and they could actually make changes for orders right there in the huddle as opposed to having to do that after the huddle. They also found that having for example, they set up a Teams channel, and they found that it was, setting up a secure Teams channel, and they found that having a way to communicate who was on the watch list electronically actually facilitated the huddle. So there are, we've certainly coached them in doing these virtual huddles, and we know that there are limitations to that, but we have also found that some CLCs have had real success in doing these virtually. That is not to say that, I mean, I'm perfectly honest in saying that there's a bell-shaped curve, and we have some CLCs that COVID has just slammed the brakes on everything for them. They've just been completely overwhelmed. And then we have the middle of the curve, and then we have some really front runners in doing that. So I'll move on here to say that the watch list huddles is the foundational practice in what we're doing in the CLCs, but we also teach them how to do other things, what we call micro root cause analysis. That's not this formal root cause analysis that you're familiar with, but done in the huddle, very deep but quick root cause analysis for issues that seem to be somewhat intractable. We also teach them how to do what we call deep dive conversations. So conversations about individual residents, again, where staff are feeling stuck, where things aren't moving, where the action plans that they put in place because of the watch list huddles just didn't seem to move the needle enough. And so devoting more time to a conversation that really, this is really about pulling in the whole person. So in CLCs, those residents live there. You need to take a whole person approach to care, and the watch list huddles help do that, but sometimes a deep dive conversation is necessary to really implement whole person care. And then we teach them how to do quality improvement projects that really are meaningful, and teach them to start with improvement projects where they will address an issue that is causing staff stress, but it is a solvable issue. It's always tempting to start with something that is really causing stress, but that might be something that would really take a long time, or it would be very difficult to change. And so one of our key mantras is start with a high impact but easy win. Something that can be changed so that your team can feel that lift of the, hey, we were able to change that. Pulling together as a team helped us make this important change. Our lives have gotten easier, and then that lift then pulls you forward. So save those really difficult problems till later, even though it's tempting to try to address them right away. Start small, pilot everything. That's another one of our mantras. So I'll end with this question. You don't necessarily need to answer it in the Q&A, because I'm also now going to turn it over to Heidi to ask whether there are questions that came through as I was doing the presentation. But how would huddles help change your culture? Think about whether or not your teamwork could benefit from the processes and structures that something like a watch list huddle can help put in place, help reduce your cycle time, help improve relational coordination and the teamwork within your culture, and therefore help create that learning system that is the ultimate goal. So I'm going to ask here whether anybody has any questions, and you're also more than welcome to email me. This is my email address here. Please be sure to put 2 N's on the end of my name if you do email me, because there is a Christine Hartmann, as there is a Christine on this presentation whom I thought I was being addressed earlier. There are different Christines, and there is a Christine Hartmann with 1 N in VA. And so we want to make sure you email the right person, which is me with the 2 N's. So I'm going to ask Heidi if she saw any questions coming through, and maybe Christine, if you were looking also, but I'm happy to take questions. And if there aren't, I'd just like to say thank you all for participating in the Q&A. This is so much more fun when all of you do that and are interacting like that. I really appreciate all of your terrific brains in this room, and hope this was useful to you. So Heidi, do you have any questions?
I do. And we've got, I'm sure you've seen some, just people are loving your session. You've gotten some great feedback in the Q&A here. But it may take me a minute to find the questions, but I do have one here, and I'll just keep going as I find them.
Okay, great.
This is wonderful information, and I'm enjoying this presentation. Do you have any information related to team development measure tool implemented in any CLC?
So team development, say those keywords again.
team development measure tool implemented?
Okay, so maybe a tool to measure how they have done in implementing, for example, these watch list huddles and the other things that we are using. So yes, we have a self-assessment that we have the CLCs do so that they can monitor the various aspects that we think are key to implementing a full sort of culture change directed program focused on LOCK. And I'm happy to share that if you email me and nudge me that you would like a copy of that self-assessment, for example, I'm more than happy to share that.
Great, thank you. Next question. How do you overcome the power dynamics so people can speak freely?
Yes, let me get to that in just a second. I just see a comment from Heather Gilmartin, and so she asked me to mention that the Relational Coordination Research Collaborative membership, so there is a Relational Coordination Research Collaborative that is a formal organization that is worldwide, and the membership in that collaborative is free to VA employees starting in March. So you can, I would tell everybody to avail themselves of that opportunity, and you can apply to use the Relational Coordination Survey for free. So the Relational Coordination Survey is an amazing survey that you can do, and you can do it over time. That's really the only way to do it, is do it once and then wait, for example, a year and then do it again. And she said more information will be shared soon, and you can certainly, Heather, I'm just going to throw you under the bus here and say you can email Heather Gilmartin at VA, and she will give you more information about that. And so you said overcoming power dynamics, right? That was the question?
Yes.
Okay, great. So power dynamics, that is an issue. And so we have multiple ways that we've done that. Power dynamics are, so leadership buy-in is critical. Often the first facilitator for a huddle is someone who has the power to make the change. It is important not to, for example, start a huddle system and process with, for example, a nursing assistant as the facilitator, because that nursing assistant has no power to actually say, okay, and next we're going to do an assessment on Mr. Jones, and this is the next plan to do this. That kind of culture can be built over time, but initially it needs to be someone who has actual power, so like a nurse manager, for example, to make changes that come out of the action plans for the huddle. So involving that leadership, getting that leadership buy-in, but then in terms of the power dynamics within that huddle scenario, doing that go round. And some of those videos on managing, so that if you have people who are speaking a lot, how to manage that so that you manage to go around the room every single time for every single person you're discussing, helps level those power dynamics, because people will hear from everyone. Another thing that some CLCs have done, and this is by no means universally applicable, is to put their name badges in a basket when they walk into the room, just to give that symbolic lift of we're all equal here. I may be the physician, you may be the housekeeper, but my badge is going in there. And in this room, I'm just Tina, and you're just Heidi. It doesn't matter silos, job descriptions. It's the information that we all have that we are here to share for the benefit of the veteran. And that has also been a powerful tool that some places have used.
Great, thank you. Okay, so it is 12:59. I have two questions that I would like to try to sneak in quick before we close out, possibly.
Yes, I can do that.
How do you reduce cycle time without making clinicians feel overburdened with additional communication?
So that is a great question, and I think that in our experience, I can say that as they implement these huddles, they understand, they realize, they feel, they experience reduced cycle time means more communication is taking place about the key issues, and that their life becomes actually less hectic because they have the information that they need when they need it.
Great, thank you. And the next question, how is COVID impacting huddles at CLCs?
Yes, I think I answered that question earlier in my presentation because I saw that coming through. Yep.
Okay, good. Okay, perfect. So that we are going to wrap things up right there. I'm sure we do have a few other questions out here that I missed, but as Tina said, her email address is on the screen right here. Tina or Christine, two separate people. Either of you have any closing remarks you'd like to make before we close the session out here?
Well, I already said thank you to everybody. I thank you to QUERI for enabling this session, and thanks to all the participants, because without you, it wouldn't have been so great. So thank you so much.
Thank you.
Yep, and this is Christine. I'll just say thank you to Teen so much. This was a truly wonderful presentation. You can tell from all the comments. And thank you to everyone that joined. And next month, our session will be hosted by Ann Sales and Maria Fernandez, so you can keep your eye out for information about that.